Is alternative evidence the holy grail for underwriters? Well, not necessarily. Today I'm going to discuss several things you need to know when thinking about incorporating alternative evidence into your underwriting programs. Over the past 18 months, we all know that the insurance industry has faced some challenges, not the least of which was being able to get your traditional evidence, namely your labs and exams. And this is really because examiners had to shut down temporarily. And honestly, clients just didn't feel comfortable with that face-to-face interaction. But our industry really had a determination to continue to move forward and not shut down, but instead to continue to protect families during this crucial time. And what they did was they started to look towards alternative evidence, your electronic health records, your medical claims, and your lab picture, for instance. So right now we're in a place where these limitations are starting to lift. And as they do, the insurers are starting to see that there's added benefits beyond that stopgap. They can be faster, they can be cheaper, and sometimes they can be a little bit more robust. So being able to understand your block of business and the alternative evidence and your use cases will really help you understand what alternative is to you and to your business needs. Alternative evidence is nothing if not variable. Variable in types of information available, the depth of the information available, as well as variable in formatting. So let's take an example of what is meant by this. By comparing your clinical labs, for instance, what you see in lab picture and electronic health records, to your more traditional insurance labs. For the most part, you're going to expect to see a consistent set of labs in your insurance labs, including GGT and cotinine. Clinical labs, on the other hand, can be very nuanced and specific to a client's unique medical history. You most likely will not see that GGT or cotinine. However, you can expect to see a series of, say, A1Cs for a diabetic or TSHs for someone who is being followed for thyroid disease to help the clinician and the underwriter to determine the degree of control. Now let's start to fold in some other pieces of alternative evidence. For instance, your medical claims. Here you can expect to see the same proposed insured having an order for an A1C or a TSH, but you're not going to actually see the results. So there's definitely a contrast here to what you're seeing with your clinical labs, electronic health records, as well as your claims data. So what about the variability in formatting? Many providers offer normalization and decisioning tools. So, for example, some alternative evidence providers offer scores to help underwriters in their risk selection. Others offer deduplication of codes to optimize the underwriter's review. So again, understanding that block of business that you want to use it for and how you want to use it will help you to best incorporate alternative evidence into your underwriting programs. In speaking with underwriters, most seem to have a keen understanding and appreciation for the speed of alternative evidence. Most can usually be retrieved within 24 hours. There's also cost savings that they appreciate, and they understand that the quality can be variable. What seems to surprise most underwriters is the variability and availability of alternative evidence. Many times, underwriters seem surprised to find out that if they get a hit on an applicant, that it doesn't necessarily mean that they have an all-access pass to the applicant's overall medical history. They also seem surprised by the geographical implications of the hit. So understanding that there is variability in the data that can be pulled back based off the data provider's network is something that I would say is often misunderstood. Insurers are finding benefit in using alternative evidence beyond using it as a stopgap. In recent years, we've seen a push by new insurance clients to provide an ecosystem similar to products outside of our industry. This means that clients want quick, personalized decisions with costs that don't break the bank. Many in the insurance industry are looking to alternative evidence to help them bridge that gap. This has helped with speed of decision, and most alternative evidence can be pulled back within 24 hours. Also, personalization. We're pulling back the client's own personal medical history. And the cost can be anywhere from half the price or a third of the price, even, of our traditional medical evidence. That's not to say that alternative evidence is the holy grail of underwriting evidence. As we've talked about before, availability, consistency, and recency of the data pose challenges. And any point of selection can be a point of anti-selection. So careful consideration of best use and continued monitoring are going to be key to incorporating alternative evidence into your programs. So when we're talking about a longitudinal view, in this context, we're talking about repeated observation of a proposed insured's health over a period of time. So unlike your traditional insurance labs that just provide that snapshot, alternative evidence can provide the longitudinal view, which is so important in assessing consistency as well as control of medical impairments. So to illustrate this, let's talk about a 55-year-old man who comes in for insurance. He gets his insurance labs drawn, and he has a PSA of 2.5, which is well within normal limits. The underwriter looks at it, feels comfortable with it, and approves it a Preferred Plus. Now let's say that we layer in our alternative evidence. And what we see is 2 months earlier, they had a PSA of 1.5, and 6 months before that, a PSA of 1.0. Now the PSA velocity, or rapid rise, throws up a red flag for the underwriter that further testing needs to be completed because they may have some prostate cancer, they may not, but we need to look into it further. Without that longitudinal view, the underwriter would have taken a significantly different path in assessing the risk. This is not a new concept. This is something that we do all of the time with attending physician statements, especially with the higher age and face brackets. So what can we do with alternative evidence? Can we look at it in different age brackets? Can it help us in assessing our risk? Again, despite all of the changes, be open to using alternative evidence and see how it best fits your needs.